So our next talk is on oscillometry. I would like to invite the chairpersons, Dr. Sunitha, Dr. Abhishek Patil, and Dr. Sandeep Grover to kindly come on the chair. I would like to invite the faculty for the same. Dr. Balachandra BV, please.
Thank you. It gives immense pleasure for me to introduce Dr. Balachandra PV. I work in the same institute where he is located, that is Manipal, Bangalore, and we depend on on him for a lot of allergy-related issues. So he's a consultant pediatrician at his own center as well as Manipal Old Airport Road, Bangalore. He has specialization in allergy, and also he runs a MedTrain program where he trains in allergy basics, which is an online plus offline program, I think. So with that, I hand over to you, sir. We learned from Dr. Deepak, Dr. Talwar's talk regarding spirometry, but the problem with spirometry is, it is operator dependent, it's patient dependent also, where patient puts a lot of effort. Well, I got to know that oscillometry is something where you use the tidal breathing of the patients to get those graphs. But if slightly discomfortable territory was lung functions, oscillometry is completely unknown to us rheumatologists. So I hope you make us understand this topic. So thank you.
Okay. Good morning to all of you. Sarah set a very high level of expectations from me. I'll try my best. So honestly, after spirometry, oscillometry, if you are listening for the first time, it's too much. It's actually too much. What happens is, even after 5 times, 10 times learning the spirometry, learning the oscillometry, even if you leave a 3-4 months gap, you find it difficult to interpret a report and you try to miss out on the concepts and the logics. Now, I will try my best to make it as simple and as easy for you. Without understanding the concepts, interpreting only the report is only momentary. You will lose out within few months. So I'll take it step by step. My whole one intention here is, I have given you 3 reports of oscillometry. I want you to interpret this at the end of my presentation. Now it might look little complex, now it might look little different, but at the end of my presentation, if you are able to interpret these reports, that means I've done my job. Okay, to start with, how many of you are using oscillometry now? Only 3 of you, and all 3 of you are pulmonologists or an allergist here. So let me see, this is a challenge to me, not for you, to me, to make sure that you interpret this oscillometry report, and also to impress you that yes, there is a value in using oscillometry in your practice. All of you have decided to start practicing allergy and asthma. If you are practicing allergy and asthma without a pulmonary function test, it is incomplete. After this course or after this presentation, after this conference, when you go back and when you decide that you want to do a allergy and asthma, first thing what you need to do is either spirometry or oscillometry, you have to have it in your office. Otherwise you will never start it also, because you will always have an underconfidence that have I really diagnosed it, or shall I refer off to a pulmonologist. And the moment you start thinking that no, I have a machine, I will test it, I will look at the report, I will start evaluating the patient, that means there's a different kind of a branding that you are positioning in the society. You are positioning yourself as not just an immunologist, you are positioning yourself as an immunologist and allergist. So that's the crucial point. What I am trying to say is, next few days or weeks, if you are not going to decide on this, this whole effort is just waste of time. So that's what I want to impress. Now, first I want to thank Dr. Sandeep Salvi sir, Dr. Disha Gorpade and Dr. Sanjay Bafna, from whom I learned this oscillometry. Trust me, I have attended at least about 5 times their workshop and I have listened to their lectures about 100 times re-recorded in the system, then I was able to understand the concepts. It took me nearly 100 times to stand in front of you and speak to you. It wasn't so easy. Okay, now how am I going to go with my lecture is, first few minutes I am going to spend on introducing to the FOT, then followed by concepts, followed by terminologies, and some more terminologies when it comes to the values and graphs, normal values and graphs, and finally stepwise interpretation and examples. At every step I am going to stop, I am going to discuss with you whether you have understood. If you have understood, I will go to the next step, because if you have not understood the introduction or the concepts, then there is no point in going to the next level of it. Okay, be with me, I need your focus and attention, otherwise we won't be able to interpret it at the end of this presentation. So this spirometry looks at the vital capacity, which measures the inspiratory reserve volume, tidal volume and the expiratory reserve volume. The body plethysmography, which measures the total lung capacity. The best part of the oscillometry is, all you need to do is breathe normally into the mouthpiece. Just breathe normally. As a pediatrician, I am a pediatrician and allergy, and most of my practice is 50-50%. Now I also see adult allergy and asthma. So starting from 3-4 year age group, even till about 60, 70, 75, I am able to do oscillometry easily, because my patient is he has to just do a simple normal tidal breathing. Okay. Now few differences is, most important part is patient cooperation. I have had a success with 4-year 8-month-old child doing a spirometry, but I have had failures with 10-year-old child and adult not able to understand and do a spirometry. So I feel proud when I say 4-year 8 month, but I feel so difficult that an adult or an older child is not able to understand after great effort. Okay, forget about this episode, come back after 1 month, some people are not able to understand. Effort dependent, you saw that Dr. Deepak Talwar sir, how much effort was needed to do it. Not every patient will understand to perform that. And you know, effort dependent, I mean that there is a same amount of effort required from a good technician. If your technician is not putting his heart and soul, you cannot get a good spirometry report. Forceful maneuver, technician dependent, 6 years is generally, but plus minus variable. Clinical correlation, again there has been a little difference between the pulmonologist and non-pulmonologist, I can say. My thing is, there are many times where I felt that clinically it was not correlating, though it was looking like an asthma, it was not fitting into the asthma when I start reporting the spirometry. Small airway obstruction is generally not very easily picked up. So oscillometry is more sensitive, especially with respect to small airways, and it is a normal tidal breathing, 3-4 years and above, gives little more information than spirometry, considered as a future of lung function test. But also I would like to caution you, spirometry has stood test for 150 years and probably oscillometry somewhere about 50 years now, and most of the data is being generated only in the last 1.5 decade. So that means spirometry has stood for so long, it is still the gold standard, but there is a lot of data which is coming up in the oscillometry which might become a future, but as of now it is not replacing spirometry, it is walking along with that and trying to see where it positions himself. Okay, so basically what is this oscillometry? If I have to explain this oscillometry in one word, it is just measuring the resistance at different parts of the lung, can be a central airway, smaller airways or lung parenchyma, at a different phase of breath cycle. It can be measured at inspiration, it can be measured at expiration, it can be measured at the early inspiration, late inspiration, at different phases of the breath cycle using pressure flow measurement and sound waves in tidal breathing. This is not a textbook definition. One day I was just closing my eyes and I was thinking that if I have to put it in one line, what will I do? I just got this thought and I have put it across. But this explains a lot. This explains a lot that you are measuring at different parts of the lung, different phases of breath cycle using a pressure flow and sound waves. So now I want you to focus here in this particular slide, because in the introduction part I want you to understand this. Imagine a patient here is breathing through the mouthpiece. Okay, he is doing a normal tidal breathing. He is not doing any forceful maneuver. Sorry. Okay, so the person is breathing a normal tidal breathing. For that particular person, on the other side of the mouthpiece, you give some kind of a pressure wave, which is nothing but a sound waves. Okay, some kind of an oscillating piston or some kind of a speaker or something which can produce a sound waves. He is breathing that side through a mouthpiece, and this side you put some kind of a sound waves. Okay, now the patient is already normally tidal breathing. The sound waves impinges on the tidal breathing. Are you all with me now? He is doing a tidal breathing. On the other side, some sound waves is traveling, and sound waves are getting impinged on the tidal breathing. So sound waves are entering the mouth, airways, lungs as of now. Now you put two sensors, pressure sensor and flow sensor. Okay, these are the sensors which are sensing what is happening with respect to the pressure and the flow when the sound waves are traveling. Consider as of now this is a normal lung. There is no pathology associated. Even normal lung has got some resistance. Okay, agree with me? Normal lung has got some resistance. You all agree with me, right? Okay, so resistance is there, pressure and flow. There will be some amount of changes in the pressure and flow based on the resistance. Okay, so now imagine if there is a more obstruction. You are looking at an obstructive airway disease. Okay, in an obstructive airway disease, the pressure and flow will be different when compared to the normal lungs. You agree with me? All of you agree with me, right? If it is a normal airway, the pressure and flow will be different. If it is an abnormal lung, the pressure and flow will be different. That's all I want you to understand at this stage. I will come back to this picture again and again, taking you to more, making you more understand these concepts. This is not working. Okay. So, coming back to the same logic here, okay, there is a tidal breath and there is a sound waves which are impinged there, and here speaker which is producing the sound waves which is entering into the lungs. There is a pressure and flow which is measured. If the lungs are normal, there will be a certain change in the pressure and flow. If the lungs are abnormal, there will be a much more change in the pressure and flow. So pressure by flow is equal to resistance. So based on resistance, the pressure will change, the flow will change. Are you clear with this concept? Because this is the concept which is going to make you understand how we are using the values at all. So there is a more resistance here, more change in the pressure and flow. There is a normal lungs here, the difference with the pressure and flow will be different. So I want you to stay there. I will come back to that picture again and again, because right now I am introducing you to oscillometry. I am not taking you to the concepts at all. I am introducing to the oscillometry. Here, what is oscillometry is the sound waves which are produced, which enters into the lungs. There are different types of sound waves. Okay, single frequency sound wave, that is only frequency is like 5 hertz is produced, only 5 hertz is produced for few seconds. Like they say about for 3 to 5 seconds only 5 hertz is produced. After 5 seconds 10 hertz is produced. After 10 seconds 15 hertz is produced. So at a given point of time single frequency sound is produced, that is called single frequency sound wave, which is called oscillometry, forced oscillometry test. There is something called as pseudo random noise. Okay, what is pseudo random noise? Pseudo random noise is technically a single frequency sound wave, but here the prime number frequency is used 3, 5 and 7. Here it is 5, 10, 15 because these 5, 10, if it is a number which multiplyable, then they generally interfere with the values. When 5 hertz is going and 10 hertz is coming, they can get cancellation happen. There can be a possibility of minor level of error. To counter that, they have kept the prime number where there is no cancellation can happen. So this is 3, 5 and 7 hertz. What is impulse oscillometry? That impulse means 5 hertz, 10 hertz, 15 hertz, 20 hertz, whatever the hertz are all packaged into one single impulse. So at a given point of time, all the frequencies are reaching and then reflecting back. You can understand that is the difference, because when you hear these terminologies, single frequency, pseudo random noise, impulse oscillometry, you will get confused, but all are working on the same principle. But the way the sound waves are being delivered at a given point of time, that is what decides if it is a single frequency or a impulse. If you are giving a prime number, then that becomes a pseudo random noise. Are we clear? Are we good till now? So this is what it is. FOT was forced oscillometry versus impulse oscillometry. Now to be little more different is FOT is a gentler impulse because at a given point of time single frequency is going, and provides good time resolution with measures of respiratory resistance because single frequency is going, so there is a possibility of analyzing the changes happening at that given point of time. It is cheaper also, takes little longer, about 30-35 seconds. IOS is about 25 seconds, produces little discomfort because all the impulses are going at one point of time, and reduced resolutions because there is no time for analyzing it, though there are sophisticated softwares which analyzes it. It's okay, you don't have to know much differences about this. Basically there are two terms, both means the same thing. It is just the way the sound waves are being delivered, that is what is important. Now the applications of oscillometry is in asthma, COPD, post-surgery, post-transplant, interstitial lung diseases, critical care, environmental and occupational exposures, response to bronchodilators, bronchoprovocation. As one of the doctor was asking, it can be even connected even when a patient is on a ventilator, and you can measure the resistance, how much it is, because it is just a tidal breathing. So they don't have to do any forceful maneuvers. But here in this session, we are focusing mostly onto the obstructive part of it and a little bit on the restrictive part of it. But the uses of oscillometry is much more. Even in an obstructive sleep apnea, even in post-tuberculosis, many conditions it can be used and it can be applied. Okay, so till now we have just introduced you to oscillometry. What we have spoken is oscillometry is more sensitive, gives more detailed information of which part of the lung, what changes are happening at which different parts of the lung. Easy to perform, possible from a child as young as 3 to 4 years to about old age, may be predicted as a future of lung function test. Now till now are we good? Can I move forward, or is there any questions or any doubts that you want to clarify before we go ahead? We are good now? Okay. So now the second part is the concepts. So the concepts of the lung oscillometry. One is this water pipe concept, which is also called pressure flow resistance concept, FM radio, AM radio concept, and the cricket stadium concept. These two definitely I have taken it up from Dr. Salvi's lectures, and this is something which when I am talking to that, my students only came up with this. Now why these concepts have been named like this or made it like this, to make it more easier for you to understand that. Now we discussed about lung oscillometry, sound wave being produced from the mouth one end and the patient is breathing. Now imagine that in your house you are gardening or you are watering the plants to the garden. One end of the pipe is connected to the tap, another end of the pipe which you are using it to water the plants. So water is flowing through that. Are we good till now? What happens if somebody stamps in the middle? If somebody has put their foot onto the pipe, what will happen? Flow decreases, what happens towards the end of the tap? Increased pressure. Okay, so what happened is physically somebody is obstructing the pipe, causing decrease in flow, increase in the pressure. Same thing actually happens even in the Ohm's law. Even the way the current is flowing, voltage is driving the current to flow, but if there is a resistance of the material, wire or anything, it decreases the current flow. This is what is Ohm's law, which all of us studied in our 6th standard. Same concept I am telling here. There is a pressure which is pushing the flow. If there is an obstruction, it needs an increased amount of pressure to make that flow happen. Okay, and why? Because there is an obstruction, decreased airway caliber and increased resistance. Now let us apply that into the real clinical scenario. Whatever we learned, that water pipe concept, let us apply to the clinical scenario. Here the patient is breathing a tidal breathing. Now we apply a sound wave. The sound waves are impinged onto the tidal breathing, and there are sensors, pressure sensor, flow sensors are present there. Please note, these sensors are present outside, nothing inside the patient's lung. We are interpreting the resistance present inside the patient's lung by keeping the sensors outside. Okay, so now what will happen if it is a normal airway? If it is a normal airway, we saw that pressure divided by flow is equal to resistance. Obstruction means more resistance. We all agree with that. So if it is a normal airway, also has a certain level of resistance. So if pressure by flow is equal to resistance, if resistance is a particular level, pressure and flow will be also present, but they are at a particular level. But if there is a very narrow airway, very narrow airway, resistance is more, that means it will reflect on the change in the pressure and change in the flow, right? You agree with me now? So normal airway, obstructed airway, the severity of the obstruction. If it is a mild obstruction, there is a certain change in the pressure and flow. If it is a severe obstruction, the change in the pressure and flow will be much more significant. Do you agree with me? That is the concept of this pressure flow or a water pipe concept. That's how whatever the changes are happening here is the changes in the pressure and flow are analyzed. So resistance in the lung is measured by the pressure and flow sensor which are present outside the patient. Same thing here. So sound waves are entering here. If it's a normal airway passage, normal resistance. Narrow airway, more resistance. So more resistance, then more pressure will change, and the sensors will pick up and converts it into how much resistance is present in the airways. So we are all good now. We understood how the resistance in the lungs is interpreted in the change in the pressure and flow in the machine. Now, how do I know that which part of the lung is affected? Whether the central airway, middle airways, smaller airways, or whether there is a problem in the lung parenchyma. How do I know that? Because anywhere there is a resistance, the change in the pressure and flow will happen. But how do I know which part of the lung is affected? So let us understand this FM radio, AM radio concept kind. See, now we all know that AM radio, which is probably played in New Delhi, you can hear the same song in Kanyakumari or in a Kashmir or in Mumbai or in Northeast. Why the same song, same radio jockey you can hear anywhere in India? But if it's an FM radio, only in that particular city you can hear. Probably in Ahmedabad you can hear. Okay, maybe 98.3 you can hear it in Ahmedabad, but when you come to Bangalore, it will be a Kannada song, it will be a different song, same 98.3 but different jockey, different song. Why? Because the FM songs don't travel beyond a particular city limits, maybe 40 kilometer, but AM sounds will travel probably 2000, 3000 kilometers. We agree with that? All of you are with me now? Okay. Why is that happens is because AM radio uses 1 megahertz, okay, that is a lower frequency. because it is a lower frequency, it travels thousands of kilometers. FM radio uses 100 megahertz, which travels a shorter distance. Lower frequency, farther distance, higher frequency, shorter distance. Okay, the same logic will be applied in the test also. So this is the way the sound waves which travel, okay, with the wavelength. This is the way which moves from one place to another place. So this is again to show that in the oscillometry test we use multiple frequencies, 3 hertz, 5 hertz, 7 hertz, okay, 11 hertz, 10 hertz, 20 hertz, 30 hertz. So we use different frequency of sounds. When we use about 5 hertz or 3 hertz or 5 hertz, it travels from mouth to the alveoli. Because it is a 3 hertz or 5 hertz is a lower frequency, it is traveling for farther distance. When you use about 20 hertz or 30 hertz, it travels only to the central airways, probably till about 7th generation or 8th generation of the airways. We know that there are 23 generations and then only the air transfers into the oxygen gets transferred. So in the 23 generations, central airways is probably up to 7 to 8 generation, and below that is a smaller airways. Okay, so when you use 30 hertz or 20 hertz, it is traveling till only 7th generation. When you are using the 5 hertz, it is traveling till the alveoli part of it. Are we clear till now? Because lower frequency, farther distance, higher frequency, shorter distance. So let us use this concept only and see that about 20 hertz or 30 hertz, when they are used, they are traveling to the central airways. When 5 hertz it is used, it is traveling till the alveoli. So, based on this, we will be able to tell which segment of the lung is having more resistance. Okay, say for example, if it is at 20 hertz or 30 hertz is the one, when that particular sound wave goes, there is more resistance which is shown, more changes in the pressure and flow, then I know that central airways are the affected. Okay, similarly, if a particular frequency like say 5 hertz, which travels from upper part to middle part to the lower airway, 5 hertz travel completely. So if there is a changes in the 5 hertz, then I know that the obstruction can be in the central airway or a lower airway, because it is traveling from above to down. But when I minus R20 minus by R5, there is a mathematical calculation, you remove the R20 by R5, then you are measuring only the smaller airways. So by this I am able to tell which anatomical location there is more problem, more obstruction being present, and in which anatomical location there is a good reversibility, which anatomical location there is no good reversibility, whatever it is. Are we good till now? Okay, how the FM radio concept turns out into a realistically our way of analyzing which part of the segment is affected. Now again coming to, can I ask one question, not for the pulmonologist or anybody, which part of the airway has a maximum resistance in the lungs? Starting from nose to the smaller airways or 23rd generation, wherever it is, where do we have the maximum resistance? Nose? Smaller airways. How many of you lift your hand, nose or smaller airways? Smaller airways? All smaller airways. Okay, how many of you tell that it is nose? Okay, so that's where this cricket stadium concept. What is this cricket stadium concept is, imagine the 50,000 people. Okay, I'm just giving you a number, 50,000 people are entering to only one gate. To the whole cricket stadium, there is only one gate. 50,000 people are entering. Is it easy? Difficult, right? It's not working from here. Okay, once you enter the main gate, you have hundreds and hundreds of small gates are there. Now people distributed across the small gates. Will there be more resistance here or more resistance here? In the first gate, right? This is the first gate. This is the first gate where complete tidal volume, if it is 500 ml or inspiratory reserve probably 3.5 liter, I am taking a deep breath, has to enter here. but once it goes inside the central airways and gets distributed into the millions of smaller airways, though they are very tiny, but the amount of air going in that is much lesser. Cross sectional diameter, if you see, no, small airways, all small airways put together, it's a much bigger pipe when compared to one small pipe. So the maximum resistance is present in the nose and the central airways compared to the smaller airways. So this is a logic, similar logic it works. Why I wanted to tell you is that's the usefulness of oscillometry in picking up the smaller airways. So above the vocal cord is 66% of resistance, larger airways is 20%, smaller airways is 7%, and respiratory zone is 7%. Why this is very important for us is there is something called SAD asthma, small airway dysfunction asthma, okay, which is difficulty to treat, more severe form of disease, more uncontrolled asthma, night awakenings, exercise induced asthma, smoking related, and more in females. And 50% of the asthma has a small airway dysfunction dominance. It can be either only small airway asthma, or it can be both, but where small airway is dominating it. And it's also important that when you have a small airway dysfunction asthma, the MDIs what you use might vary. The MDI which has got a much more fine, about 2 to 3 micron size, you have to use it when compared to the regular inhaled corticosteroids or regular bronchodilators, which enter into the major part of the airways and doesn't enter into the small airways. So your selection of medicines will be different if you define this patient is dominated by small airway dysfunction asthma. You can't use the same inhaler to everybody. So that is the reason why I put this, because oscillometry is extremely good in identifying the small airway dysfunction asthma, and once oscillometry has started been using, more and more SAD asthmas have been defined. Okay, so are we good till now? Concepts? All of you are with me till now? Okay. Okay, now I know it's too hectic for you to keep on focusing on this, but stay with me. These are the terminologies which you should know before we start interpreting the report. Now I am preparing you to interpret a report. Till now I gave you the concepts, science behind it, but I am trying to make you to interpret a report. Resistance, reactance, inertance, capacitance, compliance, and elastance. Okay. Now what is impedance? Impedance means when a sound wave is produced, it enters into the mouth, throat, central airway, smaller airways, parenchyma. When it is entering, the sum of all the forces which oppose the generated impulse is respiratory impedance. Sum of all the forces, it can be in the mouth, it can be in the throat, it can be the lung parenchyma, anywhere, all put together, whatever it is opposing it, that is the impedance of the, that is the impedance. Okay. So as of now, just understand this concept. We are not using the I value or impedance value to interpret the report, but this is the concept for that. Now what is impedance? If I have to grossly categorize, this is grossly categorize, impedance is nothing but the air resistance offered by the airways. Okay, this is from mouth to the alveoli, and second thing is within the alveoli. So the resistance is offered even in the alveoli based on the elasticity, all those things. So impedance means it is offered by the airway and the lung parenchyma. Okay. So impedance is equal to resistance plus reactance. Reactance I will talk about it later, don't worry. Right now it is say that it is by airway plus the lung parenchyma. So what is impedance? Sorry, let me explain this, otherwise. The resistance which is offered by the lung parenchyma, okay, the resistance which is offered by the lung parenchyma, there is also an air which is present in the lungs. You don't have vacuum, right? There is already some amount of air which is present, okay. So normally probably the reserve volume, functional reserve volume of 2.5 liter in a woman and 3.5 liter in a male will always be there. So that including the resistance which is offered by the existing air plus the lung parenchyma all put together is called reactance. Okay. So the airway is the resistance offered by the airway is called as resistance, and the air column plus the lung parenchyma is called reactance. So now impedance means it is a total resistance. In that, what is offered by the airway is called resistance, what is offered by the air column plus the lung parenchyma is called reactance. So what is resistance? It is the resistance of the respiratory tract to the airflow during inhalation and exhalation. It is offered by, you can divide further resistance into two components, central airways and the peripheral airways. That is till 7th generation, and from 7th generation to 23rd generation. So the resistance can also be offered by secretions, mucus, anything which is present. So we also already discussed it. When it comes to the resistance, maximum is by the central, which is 66% above the vocal cord, 20% large airways, 7% small airways, and 7% respiratory zone. So this is what is called as a resistance. I'll skip, yeah. So the resistance can be further categorized into central and peripheral. Central is till the 7th generation and peripheral is from 7th generation to 23rd generation. So impedance is categorized into resistance and reactance. Impedance is the total resistance which has been offered. This is from the airways, this is from the air column and the lung parenchyma. In the airways, central and peripheral. Now what is reactance? It is a resistance offered by the air present in the lung and the lung parenchyma. So the resistance offered by the air which is present in the lungs is called as inertance. There is a different name. The resistance offered by the air in the lungs is called inertance, and the lung parenchyma is called capacitance. Okay. So again, as I told, there is something called functional residual capacity. At any time, we have about 2.5 to 3.5 liter of air which is present inside our lungs. That's why we are able to hold breath for longer time. Now, this air column itself will offer a resistance for the sound waves entering the lungs. That component is called as inertance. Whereas the lung parenchyma, the alveoli, all those things which offer a resistance is called capacitance. Okay, reactance has got two components, inertance, air column, capacitance is a lung parenchyma. Okay, now coming back to reactance, we have capacitance and inertance. Are you good till here? All of you are good till here? Okay. Now, when it comes to the capacitance of the lung parenchyma, the capacitance of the lung, there are two terminologies which you want to know is, one is called compliance. What is compliance is how easily lungs will expand. And classic example is emphysema, where lungs will easily expand. Okay. Another terminology is elastance. How easily the lung collapses or how easily the lungs go back to its original position. The classic example is fibrosis. In lung fibrosis, what happens? It doesn't expand so easily. It's quite difficult for while inspiration, but whatever has expanded, it comes back very fast. So elastance is how easily or how fast the alveoli can come back to its original position. Compliance is how easily the alveoli can expand. Okay. So capacitance has two components, compliance and elastance. Compliance is how easily it expands. The classic example is emphysema. The elastance is how easily the lungs can go back to its original state, that is interstitial fibrosis. So don't worry, we are done. This is nearly complete understanding. So impedance is the total resistance offered. Resistance is by the airways, reactance is by the air column and the lung parenchyma. In the resistance, I have divided into central and the peripheral, which is 7 generation and below 7 generation. Reactance is capacitance and inertance. Inertance is by the air column which is present, 2.5 to 3.5 liter. We don't know the actual implications of that, so we are not going to use it. Capacitance is elastance and compliance. Basically, it is how easily lungs will expand, how easily lungs will collapse. Are we good till here? Okay. Might be we are just going back to our first year MBBS, learning it and coming back. Sometimes we are going to 6th standard physics of learning the Ohm's law and coming back. So it is needed here, because if you understand these concepts when you are interpreting the report, it becomes like a fraction of second only it takes to interpret a report. Okay. Now we have understood the terminologies related to the lung volumes or lung physiology related. Now I am starting to take you through the how the values are interpreted in the test. Okay, the paper what has been given to you will have this kind of a graphs and this kind of a curves, but here some of the terminologies I still have to introduce it to you related to the test part of it. Till now the terminologies what was introduced is related to the lung physiology and pathology, but here it is related to the test part of it. Now please look at this graph, it is very very important. There are your paper what you have might have some R3 to R20 or R30, it's okay, everything means the same thing. Here I put the graph here 5. What is 5 is the sound wave which is going at 5 Hertz frequency. What is 5? Sound wave going at 5 Hertz frequency. Now say somewhere here the sound wave going at 10 Hertz frequency, somewhere here the sound wave going at 20 Hertz frequency. Okay, we all learned the FM radio, AM radio. Why we are classifying like that? Because each sound wave reaches a particular region of the lung, it will tell me where the pathology is. So 5 Hertz, 10 Hertz, 15 Hertz, 20 Hertz. Now this is a zero line. This is a zero line. Above that is positive, below that is negative. Okay, why it is represented like that I will tell you also. Probably in your graph it is given as a 2 different pictures in your paper what is been given, but I have put it everything in one paper here. Now in the zero line above that is positive, which measures the respiratory resistance. Resistance means the airways, central airways, peripheral airways. Are we good till now? So when it is an R5, which is a 5th frequency in the sound wave, it enters through the mouth, throat, chest, lungs. So it is entering the complete from mouth to the alveoli. Anywhere there is a problem, it will show the reflection. So R5 measures any abnormality present in the central airways as well as the peripheral airways. Though it can reach till the bottom of the lung, to reach the bottom of the lung it has to reach from here. Okay, so it will measure any change in the central as well as the peripheral. But R20, that will travel only till the central airways. R20 will not even reach the peripheral airways. So if R20 is abnormal, then I know that something is happening in the central airways or the mouth, throat or the central airways only. It can't be anywhere else. Are we good with that? Now when I minus R20 minus R5, then I am going to get a pure small airway values. Okay. So this is R5, that is resistance at the 5 frequency. Normally is up to 4 centimeter of water, which I will come back to that again. Okay, which is mostly a straight line, mostly, not always, it's a straight line. So this is a zero line, resistance is represented as a above the zero line, and it is mostly almost in a healthy person it will be like a straight line, not a straight line. So this is the resistance curve. Now I told about reactance. Reactance measures 2 components. One is the airway component and second one is lung parenchyma, capacitance. So the airway, that is air column which is present in the respiratory system, that part of it is called inertance, which is above the zero line again. Okay, this part, this blue line which is above this particular line, right, that is the inertance column. That is the air which is present inside the lungs is attributing it to that. This part is attributed by the capacitance part of the lung. That is the lung elastance, lung compliance. So that is determining this. I would like to tell you one more thing. Please note, all the sensors are outside the patient's body, no sensors inside the patient body. When I am telling that lung capacitance here, this will also change if there is a terminal airways, small airways, if there is any variability, that will also be reflected here. Because we are not keeping any sensor, it is a mostly an kind of an interpretation. So lung parenchyma plus a fine terminal smaller airway change will be reflected here. Okay, are we good till now? Okay, so you understood this. What is R5? Is the resistance at the fifth frequency. R20, it's a complete airways. R5 is complete airways. R20 is central airways. R5 minus R20 is the peripheral airways. X5 is reactance. Sorry, I did not mention. Reactance is represented as X5. Okay. FRS and area of reactance, I will come back to that later. So now, there are another two terminologies which I need to tell you. There is something called FRS or resonant frequency. What is resonant frequency is when this reactance line starts with the negative, goes up and into the positive. As I told, that is inertance, contributed by the inertance, and this is by the capacitance and the smaller airways. The point at which it cuts the zero line is called resonant frequency. This is called resonant frequency. If you actually see, there is a triangle which is formed. This triangle is called Goldman's triangle or area of reactance. This is called area of reactance. This is what actually we are going to measure in our report and say how much is the value change and what is the condition associated with that. So the resonant frequency is a frequency at which the inertial properties of the airway, which is in the positive representation, and the capacitance of the lung parenchyma are equal. They meet at the zero line. The frequency which is 0. Usually the normal values is at the 7 to 12 hertz. See, the where it is cutting is mostly at about 7 to 12 hertz. This is the normal values. This is where it cuts the moves from negative to the positive. In both obstructive and restrictive lung diseases, FRS is increased, and this is because reactance becoming more negative at the lower frequencies in each of the diseases. I'll explain this again. Area of reactance, which I showed you, the triangle which is formed, is between the x-axis below 0 and the reactance curve. It is the area dominated by the capacitance and reflects the elastic properties of the lung, and as seen with reactance FRS, this also increases in any of the disease of the lung periphery. Means it can change even with the terminal finer small airways as well as the lung parenchyma. So it's basically lung periphery. Okay, now we are almost there. What is the time? How much? We have a time to interpret also. So, till now, okay, so we have kind of arrived at the place where we have understood what is FOT, what is oscillometry, how is it different from spirometry. We understood three concepts. Most importantly, one is a water pipe. Even in our exams, we have a allergy asthma training program, and when we gave an exams, most of them wrote water pipe concept, cricket stadium concept, and we gave them full marks. The point is, if you know the concept, that's good enough. Okay, 3 concepts: water pipe concept, radio concept. Water pipe concept is to understand how the resistance and the pressure and flow changes happens. Radio concept is to identify which part of the lung is affected, and the third cricket stadium concept is to give more emphasis on the where the resistance is least. It is in the smaller airways, and SAD asthma is much more common. One more thing which I forgot to tell you is, see, if there is any minor block in the air pipe, central air pipe, nose or anywhere, no, immediately we rush to the hospital. But why? Because already there is a huge amount of resistance offered. If you block partially, then you can't breathe. But in smaller airways, it is not like that. A smoker can smoke for 15-20 years. There might be 30-40% of the small airways can get affected. The patient will not even know. Why it is important is, small airway dysfunction is the symptoms present at very late stage, because they are not contributing to the too much of the resistance. Patient will have lot of time till he comes to the center, till he comes to the hospital, but by the time he comes to the hospital, at least I can say 30-40% of his small airways are completely damaged. Okay, so that's one more reason why we need to know the cricket stadium concept, that is a small airway concept. Later on we learnt about different terminologies. We learnt about the resistance, reactance, resistance 2 components, central and peripheral, reactance 2 components, that is the capacitance and the inertance. In capacitance we learned 2 components, which is compliance and elastance. Then we came to understanding the terminologies in interpreting the report. R5 is a frequency, 5th frequency of sound wave entering, which measures any pathology from complete airway to the parenchyma. We learnt about R20, which measures only the central airways. We learnt about R5 minus R20, which measures only the smaller airways. We learnt about reactance, which is X5. Reactance is made out of inertance and capacitance. Inertance we don't know as of now what is the value. We know the capacitance part of it. Here it starts in the negative and goes to the positive. The point which it cuts from, moving from negative to positive, that point is called resonant frequency, which is normally between 7 to 12 hertz, and the triangle which is formed is called area of reactance. So we have learnt till now. Any one of you have not understood anything, please raise your hands, because without that our next step will be useless. Yes, sir. So the reactance line, the reactance which is made out of inertance and the capacitance, that is always negative, that starts always negative. Okay, there is something called in phase and out phase, that concept we will discuss it again. It always starts negative and then moves to the positive. The point where it cuts the zero line is called resonant frequency. That's usually 7 to 12 hertz. Now when it cuts this particular line, there is actually a triangle which is formed, which is the area. This is an area actually. This area is called area of reactance. This is a reactance line, area of reactance, or Goldman's triangle. Okay. So there is a like a spirometry, whether the patient has performed the test properly or not, though it's a tidal breathing. You can ask what is there in the tidal breathing, but I want all of you to really experience it. When you are doing a tidal breathing, the sound waves enters the lungs. When the sound waves are going, you will feel that something is going inside your lungs. That's a different experience which only experience can tell. You can't describe it. You feel that something is going inside your alveoli. We know something is going to our stomach, but not to the alveoli. Okay, that's a different feeling. It's not painful. It is not in nothing. It is. It feels little different. So you need to train the patient before. So some people, even when they are doing tidal breathing, they do fast breathing or slow breathing, or they hold their breath. So you need to say that relax, just do a normal breathing. Many a times we use our hand to go up, breathe out, breathe in, breathe out. So for the patient just have to follow this. Okay, there is no forceful maneuver at all. Second thing is, first time he did a particular level of breathing, second time, first time he did normally, second time he did very slow or very fast. That also is going to interfere, because we will have a 3 times will the patient has to breathe for about 25-30 seconds. First time, second time, third time, that is called pre-test. And after giving a bronchodilator, again first time 1, 2, 3. 3 post-test and 3 pre-test. So he has to breathe in a similar fashion in the all the 3 attempts in the pre-test and all the 3 attempts in the post-test. So there is something called covariance, which measures whether the patient has performed properly or not. Okay, whether the patient has performed each time in a correct way or not. Okay, so sorry, this number what you see 8.43. okay, if in a child, if it is more than 15, you don't have to do anything, the system will prompt you. Okay, if in a child, if it is more than 15, you have to reject. In an adult, if it is more than 10, you will have to reject. Okay, so there is something called coherence at 5 hertz. This has to be less than 0.9. Okay, so one is measuring whether how are you performing the test, whether you are coughing, you are taking a deep breath, whatever it is. Another one is measuring whether first time, second time, third time you are measuring it in a similar fashion. It is something like same thing like our spirometry only. But good part is everything is analyzed by the machine and it is telling you. All you have to do is, okay, the third time you do one more 25 seconds of breathing in the fourth time. That's all it is. So okay, so now I have summarized it till now. So let us understand what is the normal values or cutoff values. This is for adults above 18-year-old. Now let me tell you few things. In spirometry, okay, you can use any machine, the values will not change. FEV1 by FVC will not change. FEV1 will not change, FVC will not change, any machine you use, because it is standardized across. As I told, it is 150-year-old. But in oscillometry, that process is still happening. If you are using one instrument to measure, there is a cutoff values for that. The same cutoff values, you can't use it for a different machine. Okay, whatever I am showing here is from one machine called Antlia Pro. In fact, I can say all my experience is with Antlia Pro only. So here the cutoff value is R5, which is 4 centimeter of water per liter per second. You can measure with centimeter water per liter per second or kilopascal per liter per second. The advantage with centimeter water per liter per second is it's a whole number. It's not like a fractional number, 1.97, all those stuff. So it's easier to remember. R5 cutoff value is 4 centimeter of water. R20 is 3 centimeters of water. R5 minus R20 is 1 centimeter water. X5 is minus 1 centimeter. Area is about 4 centimeter. FRES is 12 hertz. 12 hertz is the upper limit of it. So these numbers are important. Okay, it is there in the paper which I have given also. Also you can note down these numbers are the one. So using these numbers we are going to interpret whether it is normal, abnormal, what is happening here, the values kind. Okay. Now the values are different for different age group. For a pediatric age group, the values are this one. In pediatric age group, we don't have a cutoff values for many, we have only for these three, R5, X5 and R20. We don't have a cutoff values for FRES, we don't have a cutoff values for AX, and we don't have a cutoff values for R5 minus R20. As I told, I can say that this maximum data as of now actually being generated in our country. Okay, so even Dr. Nitin has done extremely good number of studies to arrive at the values, what is the values it is. Good number of studies are happening in our country thanks to Dr. Sandeep Salvi, Dr. Disha Gorpade and their team. They have conducted thousands and thousands of people's tests and they are interpreting the values, and many more data are coming, but still it is incomplete. We have only certain values of data which are published data. There are some amount of data which are being there which are unpublished, which I am not putting it across here to confuse you. So unpublished data I am not putting it here, but the claims are that unpublished data are as good as the Western standards and the values are as comparable as the Western standards. Okay, so whatever the values I have put, using these values we will be able to tell whether there is an obstruction, where there is an obstruction, okay, whether there is a reversibility, whether it is an obstructive or a probably, now we can't say it is restrictive, probably it is a restrictive group. We can arrive at this outcomes based on this. When it comes to reversibility, now as you saw, you need to have more than 10% or 12% increase in the volume compared to the pre-test to the post-test in the spirometry, plus 200 ml if it's an adult. Okay, so there was an increase in the volume and increase in the percentage also. In oscillometry it doesn't happen, it exactly happens opposite. Because you are given a bronchodilator, the resistance is decreased now. Previously resistance was more before you give bronchodilator, here a resistance is decreased now. What happens in R5, the resistance should decrease more than 25% compared to pre and post. FRS 20% decrease and area of reactance 40%. Okay, so this is a decrease in the resistance compared to spirometry where there is an increase in the volume. You are all with me now? Okay, now generally how does a curve, how does a graph look like? Say if this is a normal value for the resistance, okay, if this is where the graph is coming, what do you think that happening here? This part of it is 5 Hertz, this part of it is 20 Hertz, the curve is coming from here to here. So it is above the normal line. Above the normal line means there is a obstruction. Okay, above the normal line means there is a more resistance. More resistance means more obstruction. If it is here, it is more, and then it is less here, it tells that obstruction is there in both the areas, but predominantly in the small airways, and obstruction in the larger airways are also present, but less when compared to the smaller airways. So this is a patient who has got an obstructive airway disease of both central and peripheral airways, but predominantly dominated by the smaller airways. So this patient's clinical approach, this patient's management, treatment will be little different from another patient. If it is almost like a straight line, it is mostly the proximal airway obstruction. Please note, even R5 will increase even in the proximal airway because it has to go through like this. If it is like a straight line, it is like a central airway or proximal airway obstruction. How does a graph look in the reactance part of it is, starts with -1 and cuts at 7 to 12 Hertz, and there is a particular area which has been formed. If there is a smaller airway, terminal airway involvement, or if there is a lung parenchymal involvement, it will become more negative. -1 will become -2, -3, -4, -5. It cuts the triangle, it cuts the line at much towards the right side based on the severity. The more towards the right it cuts, the more bigger the triangle is formed. Does it make sense? It makes sense, right? Actually, looking at the graphical representation, you can tell what is happening inside the lungs. Okay, even without seeing the values, looking at the curves, you can tell that, okay, there is a small airway or a lung parenchyma which is involved. That is the reason why, this is not resistance, this is reactance. It's a mistake. That is why reactance has become more negative and FRS has shifted towards more right side and the area has become much bigger. Does it make sense? Okay, finally 1 or 2 slides and then we will be interpreting the reports. If it is a pure peripheral or airway obstruction, if it's a pure peripheral airway obstruction, what will happen to the R5? It increases. R20, R5 minus R20. Please, all of you, I want all of you to focus here because this is the kind of a summary of whatever you have understood till now. I want all of you to make sound, all of you to shout out, please. So what will happen to R5 minus R20 if it is a peripheral obstruction? All of you, please. X5, more negative. AX, increases. FRS, increases. Are we good? What happens in the peripheral airway? Are we good? Yes. Central airway obstruction. What happens to R5? R20? R5 minus R20? Why? Why R5 minus R20 is normal in central airways? R5 minus R20 is a peripheral airways. So it's a, there is no peripheral airways are not affected. X5, X5, reactants. Please make some sound this side also on the back rows also. Normal. Area of reactants, FRS, combined airway obstruction, central and peripheral. What happens to R5? R20, R5 minus R20, X5, AX, FRS, restrictive lung disease, pure restrictive lung disease, okay. R5, why? Because it's a measurement of airway. R20, R5 minus R20, X5, because lung parenchyma is involved. AX, FRS, you have understood this? If you have understood this, then that's all that you are able to interpret a oscillometry report. So now open your first page. I'll just take one of the paper. Yes, sir.
This
Impedance.
Inheritance.
Inheritance.
What is the cost?
Inheritance is contributed by the air column. That normally when even when I am breathing or not breathing, there is air present inside my lungs, which is called functional residual volume or residual volume. That's about 2.5 to 3.5 liter. In a male it is 3.5, women it is 2.5. The air column which is present, that also offers resistance to the sound waves which is going. That contribution is called inertance, which is in the positive part of it. Thank you, sir. So now the first page which says that forced oscillation test. Okay, first step what you are going to look at it is whether the test is valid or not. Okay, COV at R5, whether it is more than 10 in adults, more than 15 in children, then you will reject. Are we good? All of you have this paper? Yes. Okay, yeah. Second is, if at all there is a technician comments, you need to see technician comments, how difficulty or how comfortable it was. Next comes the 6 steps in interpretation in the pre-test. Okay, we have 6 components, right? So 6 steps in interpretation. So step 1 is resistance at R5. Step 1 is resistance at R5 in average column. Okay. Okay. Resistance at R5 in an average column. This is how the report will look like, average. This is how the report will look like in an average, okay. So I am telling you, look at R5 at an average column and then compare it with cutoff value which is present in the predicted. Unlike spirometry, FEV1 by FVC 80%, you don't have anything. It is like your blood sugar. Above 100 it's fasting, it is abnormal, below is normal. Okay, above 120 by 80 blood pressure is abnormal, below that is okay. It is like a cutoff value, it is like your hemoglobin, above 12 is normal, below 12 is anemia. So it's as easy as it is. there is no comparison, there is no values, there is no predicted values, there is no ratio, all those stuff kind. So the step 1 is look at the value here, compare it with that. If that is cutoff, compare with the cutoff, and if the value is more than cutoff, then it is an obstruction, that is a complete airway. R5 is a measurement of complete airway, right? So if it is lesser than that, then that is normal. Okay, there is no airway obstruction. Easy, right? Easy? Okay, that's a step 1. Step 2 is resistance at R20 in average column. Resistance at R20 in an average column. Look at in the value, it is 1.68, compare it with the predicted, and then decide whether there is a central airway obstruction is there or not. Easy, right? It is just comparing. Look at the value, compare it, and then say move on with that. Step.
I had one question. If R5 is normal, do we have to look at R20?
There is a possibility that, say, where is it? R20 might be normal, but R5 minus R20, because that would have got this and that would have compensated. For example, this can be 3.9. Okay, that can be 3.9. But here R20, the cutoff is 3, but here it can be 1.68, and R5 minus R20 can be 1.68. So one would have gone down, one would have gone up. Totally it might look normal, but lower airway would have gone up, upper airway would have showing less. Okay, sorry. So the step 3 is resistance at R5 minus R20, cutoff is 1, compare the average, and then decide whether there is a small airway obstruction is there or not. Here you are looking at the complete airway, R20 you are looking at the central airway, R5 minus R20 you are looking at the smaller airways. Are we good till now? Are we good? Okay. Step 4, look at the reactance at the X5. Look at the reactance in the X5, compare it with the cutoff, and if the value is more negative than the cutoff, the word is more negative than the cutoff, then decide on either small airway obstruction or parenchymal changes. Are we good here? Okay. Next comes FRES in average column. Where is FRES? FRES in average column. Here the predicted is not given. We know that 7 to 12 in an adult. Cutoff is, look at the average value, compare it with the cutoff, and then decide on whether there is a small airway obstruction. Again, FRES will tell you small airway obstruction and parenchymal changes. Same thing coming on to the step 6, which is an AX in the average column. Compare it with the cutoff value, and if it is more than the cutoff, then you will tell smaller airway or a parenchymal changes. Are we good till now? So looking at this, see, all you need is for 5 patients or 10 patients, look at this paper and start interpreting. Trust me, the 6th patient you don't need this, and interpreting probably will take less than about 5 seconds or 10 seconds. Okay. Now you have to see whether there is a reversibility. Okay, reversibility is seen only with the 3 values. So this is a post test. Reversibility you need to see with R5 whether it is more than 20. Sorry, it was mentioned 25, it is 20 to 25, anything is okay. It is 20% in the percentage change column. In the reversibility you will see only this column. You don't need to see any of this. You can see only this column. Percentage change. If it is more than 20%, it is reversible. For FRES, it is not mentioned here. And if it is an area of reactance, again not mentioned, it is 13.8. So look at the percentage change and look at the cutoffs and compare it, and then tell that whether there is a reversibility is present or not. For R5 it is 20, FRES it is 20, and AX it is 40% of it. Okay. So you need to remember 6 steps in the pre-test, 3 steps in the post-test, and then tell that whether there is an obstruction, or whether there is smaller airway obstruction or a central airway obstruction, or if there is a restrictions present, and if there is a reversibility or no reversibility. Reversibility, sometimes you will see 1 or 2 values are showing reversibility, another value is not showing reversibility. That's okay, you can still consider that. Okay. Now I want you to go to the real patient, okay, and start looking at the values. Yeah. No, there is no 1.06. No, I wouldn't consider. See again, no matter 1.06, 1 is a cutoff, 1.06. All values please correlate clinically. If you have a clinical context, if this patient has got a perfect context of asthma, and if no matter what report shows, report is going to help me but not going to completely make me decide. Neither oscillometry, neither spirometry. Always use. And if whenever there is a 0.1, 0.2, 0.3, you don't worry much about it. Can.
Similar for the area of AX on the higher side.
Area of reactance is 4 is a cutoff. 4 is a cutoff. Okay. So go to the next page, case 1. Okay, who is going to answer this? Any one of you can only stand up. Excuse me, doctor, I forgot. Sorry. You can only stand up and answer this. Okay, this is a patient who is 51-year-old, 89.3 kgs, okay, 160 centimeters. Now just tell me how are you going to go step by step approach and then interpret this report. So what is the first step? First step. COB. What is a COB?
So like if it is less than 10, so then we'll
What is the value in this patient? In the pre-test is?
4.7.
No, R5.
6.1.
In the post-test it is 2. So that means it is within the 10 range. So you are good to interpret this patient. There is no technician comments. Don't worry about it. Okay, now start interpreting the report.
So then look at the R5.
Ah.
It is 7.4.
Ah.
It is higher than the cutoff.
What does it tell you?
Then there is obstruction.
Where? Wait. All of you wait.
Airway.
Huh?
R5 and 2.
Anywhere in the airway.
Anywhere.
Excellent. Go ahead.
So then we'll look at the R20.
Okay, yeah, R19 it is here. Okay.
R19, then it is 6.3.
Okay.
Cutoff is 3.
Okay.
So the obstruction is at the larger, the upper
Present in the central airways.
central area.
Excellent. Go ahead. Next step.
Then we'll look at R5, R90.
Hmm.
It is 1.08, so it is minimal, mildly
Negligible.
negligible. Then we'll consider that the disease is restricted to the upper
Mostly to the central airways.
central airways.
Okay. Then.
Then we'll look at the FRS.
Okay.
FRS is 15.25,
Hmm.
higher than the cutoff.
Okay.
And the area is also on the higher side, 10.12.
Yes. Okay. Then. X5.
X5, yes sir. X5 is also more negative.
-1, -1.16. Okay.
Then we'll look at the post.
Okay. Post-wise, what all you look? R5.
R5, then FRS and the A.
R5, how much is the change?
So it is -39.
No, it is in the last column.
-40, so we'll accept.
Yes.
there is reversal.
Good reversibility. And then FRS,
FRS, it is 40.7.
it is less, not significant.
Yes.
AX,
AX is -1.
not significant. So what will you put this as?
Obstructive, upper airway obstructive disease with,
No, don't say upper airway.
okay, proximal central airway obstructive disease with reversibility.
Yeah, obstructive airway disease, predominantly central airways obstruction, because you are seeing some increase in the AX and some increase in the FRS also. So predominantly central airway obstruction with good reversibility. Okay. Can you look at the graph and tell me? The bold one is the pre-test and the dotted one is the post-test.
So the resistance has decreased,
Hmm.
and since
It is above the cutoff.
of the cutoff.
Yes. When you are looking at the graph, the shaded one tells you the normal value, the straight line tells you the pre-test, and the dotted one tells you the post-test. So you see that the straight line, which is the pre-test, is way above the shaded values, and after giving the bronchodilator, it has come much within the normal range. Okay. Now go to the next one. Who will interpret?
So FS and AX both
Are increased.
So is it because of some parenchymal or some small airway with central airway?
Maybe, we can't be very sure telling that parenchyma small airway, maybe there might be some amount of smaller airway which is present, but they are dominated by the central airways. Okay, go to the next one. Who wants to answer? It's not at all complicated. You can look at the first page where how to go with the steps and you can start answering it. You don't have to answer impromptu kind of a stuff. Who wants to answer this? Anybody? Please go ahead. Please go ahead. Please go ahead. What is the first step? Yeah, now look at the COV, validity of the test. COV, no, 7.3 and 3.1, which is good. Okay, no technician comments. Go on. Step 1. Okay. No, tell the values so that everybody knows where you are looking at it. What is the R5 in the? Okay. Okay. No, R5 9.7, normal or abnormal? Okay, R19 is? Okay, what does it tell you? Okay, R5 minus R19? Yeah, so that, what does it tell you? Central and small, combined airway. Excellent, excellent. Now next, X5. It become minus negative, too much minus it has become, minus 1 has become minus 5.98. Okay, FRES increased, AX, okay, so what does it tell you? Maybe parenchymal, but we can't be very sure. Definitely central airways, definitely peripheral airways, maybe some amount of parenchymal involvement. Okay, so now reversibility. No, reversibility. Look at only in the percentage change. Okay. Okay. No, R5, only R5 is good enough. FRES? Okay, not significant. AX? Okay, significant? Okay, so what do you put it across? Combined airway obstruction. Good reversibility. Yeah. So there is one more case which I want you to do yourself. I don't want to discuss it. I want you to go through the steps which is given in the first page and then start interpreting the last page. The third case, I want you to everybody to interpret by yourself. Much time? Time is done? We have 10 minutes. Okay. So meanwhile, I want you to know if you have any doubts, any questions, I want you to answer. So meanwhile, you can take few minutes time to answer the third one. All of you, I want you to answer. And whoever finds it difficulty, please stand up and ask me also. If anybody needs help in interpretation, you can raise your hands. I'll come there and help you out. The restrictive lung disease is something which you can diagnose. You can suspect it. See if this patient, no history is suggestive of a restrictive lung disease. Not much of an obstructive, then you'll probably take him to a next level of investigation. Here, it is clearly suggestive of an obstructive airway disease. If any patient who has got a severe level of obstruction can show some of the characters of a restrictive lung disease. That is what it is showing. This is mostly an obstructive airway disease. It is obstructive. Yeah. Now this can change by either in small airway obstruction or in parenchymal changes. Okay, because here the context is looking like an obstructive airway disease, you may not consider him to subject it to next evaluation. That's all. Same thing. No, why it's important is among the three, AX is mostly representing, there's no absolute way of saying this. AX is mostly telling parenchyma, some amount of smaller airway, but X5 and FRS is telling both smaller airway and parenchyma. AX is more sensitive for parenchymal changes. Yeah, that is what I was studying from the starting, that we are not keeping any sensor inside the lung. It is just an average calculation what is happening there. Yes. Yes, please go ahead.
So if it's more means it is
Abnormal. More means the patient has not performed the test well. It should be as low as possible. For a child it should be less than 15, for an adult it should be less than 10. 9.4, it's okay.
okay.
We can accept it. Means
How much variability?
yeah, between the one test to another test to another test, how the patient has varied, because this is an average. Average means we have done 3 times before and 3 times afterwards. So and this is an for a child, for an adult.
So here it's okay.
It's okay.
So next is
You see for that in R5 only.
Yeah.
You don't see it in this one.
इसके बाद ही
The next session. Next session is chaired by him. Sorry, we have to cut the session here because Dr. Talva has to leave us to catch a flight. So Dr. Balachandra will be with us throughout, and during the tea session we can have more interactions with him. We thank you a lot, sir, for a fruitful session. And we close this session.